Hello everyone, my name is Dr. Jit Brahmbhatt and today I'll be discussing a few footnotes on recurrent systemic embolization. So basically it is an embolus which is detached intravascular solid, liquid or a gaseous mass that is carried by a blood to a site distant from its point of origin. And if it lodges to an artery that is of a lesser caliber than the size of embolus itself, it will cause an obstruction. And that's what you call as embolization. Systemic thromboembolism for major site in arterial embolization includes almost 75% in lower extremities, 10% in brains, then it might happen in intestines, kidneys, spleen, and upper limb to a lesser extent. The consequence of systemic emboli depends on the extent of vascular supply affected by that, the tissue's vulnerability to ischemia, and the caliber of the vessel occluded. In general, the arterial emboli causes an infarction of tissues downstream to the obstructed vessel. The tissue supplied by the end arteries without any significant collateral supply will be the most susceptible. The obstruction of the blood supply leads to ischemia when prolonged embolization and necrosis leads to its atrophy. So the reperfusion after the ischemic necrosis of the tissues will show a hemorrhagic necrosis. The arrangement of arteries in heart, brain, and small intestine or stomach usually is as delineated in the schema. And the major causes of systemic embolization are usually one of the mentions here, which is either atrial fibrillation or left ventricular thrombus, cardiac tumors, rheumatic valve diseases, endocarditis, mechanical cardiac valves, mitral valve prolapse, mitral annular calcification, atrial septal aneurysm, patent foramen oval, calcified aortic stenosis, and so on. The standard method of diagnosing any of the cardiac sources of such a disease is usually transthoracic echocardiography. The echocardiography is usually pretty diagnostic if it comes to diagnosing either atrial fibrillation induced mitral valve, mitral annular calcification, or mitral valve endocarditis, or aortic valve endocarditis for that matter, or cardiac tumors, or left ventricular thrombus. The arterial emboli usually originates, the one that originates in the heart, subclavian artery or pulmonary arch, is a larger emboli, and that can occlude brachial in the upper limb, or smaller thrombi. If they go out, they might occlude the smaller calibered vessels like radial or ulnar and digital arteries. The atrial fibrillation is a well-known cause to increase the risk of systemic arterial embolization in patients with mitral valve disease primarily. So the mitral valve disease is one of the most common causes of systemic embolization through a cardiac dislodgement. The morbidity, the recurrence rate, and the mortality are considerable, and the most common involvement of such a patient subset is usually with mitral stenosis. The acute cardiogenic cerebral embolism, as we know, the cardiogenic stroke, the cryptogenic stroke, is usually the 90% patients of the cerebral embolism have heart disease as a source of embolus, and 15% of them end up in ischemic cerebral infarcts. Clinical features of recurrent embolization in cardioembolic strokes. Predisposing factors are usually low plasma levels of antithrombin 3, dehydration, overusage of diuretics, presence of rheumatic heart disease and prosthetic valves, or intracardiac thrombi. If I have to cover all the subset given, it's a separate session by itself, and I won't be able to cover all of it. So just to touch up on how do you diagnose these patients, how do you treat these patients? As I said, the most standard method of diagnosis is usually transthoracic echocardiography. You end up catching up a lot of embolus or rather the sources of emboli from the cardiac part by that. If it comes to treatment, you only have three options: medical management, intervention in form of surgical intervention. So either embolectomy or patients kept on treatment for the same with NOACs or conventional anticoagulants. If you're treating the consequences of one of these embolization, for example, if subclavian artery is occluded or the superficial femoral artery or common iliacs are occluded, you can probably do a plain balloon or angioplasty, or probably a stenting at times if the thrombus burden is too hard and your conventional therapies do not help. Catheter-directed thrombolysis is one of the means you can probably use if there's a disseminated organized thrombus, and if that clears it out, patient can probably evade the intervention in form of PTAs or the POBAs. This is how you usually probably would end up having one of these POBA procedures. The treatment, as I said, if the disease of extent of the disease is too long and the PTA is not visible, you might end up having an arterial bypass, the peripheral arterial bypass, or the embolectomy if it involves one of the vessels which is acutely occluded. IVC filter also is one of the options of recurrent thromboembolism is what you're suspecting, and they are retractable filters. You can probably take the filter out once you're sure of the secondary consequences. The newer anticoagulants, epigatran, edoxaban, apixaban, rivaroxaban, we all are familiar with the same. The conventional anticoagulants in form of acinocameral derivatives or warfarin. The potential complications of recurrent systemic embolization is right from myocardial infarction to amputation if it involves the peripheral or peripheral arteries in form of upper limb or lower limb involvement, hypoxia if it involves the pulmonary artery or vasculature, organ failure or dysfunction in form of kidney disease or intestinal obstruction if it involves mesenteric arteries, gangrene and serious secondary septic infections, septic shock, stroke, sudden cardiac arrest, a lot of complications. I would sum up that if source of embolus is detected early and you treat it likewise, you probably can prevent the recurrent systemic thromboembolism. If your consequences are too heavy and you're already in the phase of treating one of the consequential diseases, we have already discussed that newer anticoagulation, catheter-directed thrombolysis, probably a POBA or surgical intervention in form of peripheral arterial bypass grafting or embolectomy is what you probably would prefer. Thank you.